You might wonder, how does one actually learn how to perform robotic surgery? What goes into learning how to perform this complex robotic surgery for prostate cancer? We'll have a special treat today for my listeners for Prostate Cancer Awareness Month. We have an excellent interview lined up today with expert robotic prostate surgeon, Dr. Paul Maroni, so stick around. So the big question is this: how can men and those who care for them better educate themselves regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions? That is the question, and this podcast will provide the answers. On a weekly basis, we will be chatting with experts, innovators, and leaders in the field of urology, sharing useful information with the general public to improve their lives and increase their overall health. My name is Dr. Garrett Pohlman, and welcome to the Prostate Health Podcast. Prostate Health Podcast is for informational purposes only. Nothing in this podcast should be construed as medical advice. By listening to the podcast, no physician-patient relationship has been formed. For more information and counseling, you must contact your personal physician or urologist with questions about your unique situation. It is a pleasure to be able to introduce to our podcast listeners today Dr. Paul Maroni. To this day, I credit much of my early foundational groundwork in robotic surgical training to Dr. Maroni. I was fortunate to have had the opportunity to learn from him during my urology residency training at the University of Colorado Anschutz Medical Campus. From a training standpoint, the way he broke down the steps of a robotic-assisted radical prostatectomy was extremely valuable for the residents in learning how to perform this difficult procedure. So Dr. Maroni received fellowship training in urologic oncology at Indiana University. He returned to the University of Colorado Anschutz Medical Campus as a faculty member in 2007. He is the program leader of the Urologic Oncology Program. His specific clinical and academic interests center around minimally invasive therapies for prostate cancer, robotic surgery, and surgery for metastatic testicular cancer. He has performed over 1,000 robotic prostate removals. A diagnosis of cancer is certainly awful, and he views the patient relationship as a partnership and focuses on educating his patients in clear terms. He does his best to give every patient the time they deserve and uses a team approach to provide the very best cancer care. Dr. Maroni, welcome to the Prostate Health Podcast.
Hey, thanks a lot, Garrett, and happy Prostate Cancer Awareness Month. It's September 1st.
Yep. No, I think this is a great way to kick it off for sure. So, Dr. Maroni, can you briefly explain for our listeners, what is robotic surgery?
Robotic surgery uses a interface between the surgeon and the patient that involves some sort of, machinery. The main device that we use now is called a Da Vinci robot. It's built by Intuitive Surgical. And that's been primarily used for the last 2 decades in robotic surgery, and really remains to this day the primary platform that we use for robotic surgery.
Now, how is robotic surgery, kind of different from the traditional open surgery in that sense?
Well, with open surgery, we're using instruments that anybody would look at and easily identify as being surgical tools. With robotic surgery, we now have moved the surgeon somehow away from the patient, and we're using a device that uses either basically remote motion or slave motion is what we might call it, where the surgeon is the master, if you will, and then the device that's attached to a patient would be the, quote, slave. Now, the idea there is it's basically just a big remote control. We're the ones that are moving the device. This is not something magical. This is not something where, I tell patients all the time that when I'm doing robotic surgery, I don't just push a button and go get coffee and donuts, that I'm the one that's still doing the operation.
We initially started doing laparoscopic prostate surgery was without the robot. Now, what sort of advantages did that also give? And I think you kind of alluded to that a little bit with how we do it, but in comparing purely laparoscopic prostate surgery versus the robotic laparoscopic prostate surgery.
Yeah, so typically with the robot, we're using a camera and a laparoscopy. So laparoscopy is, there's the space around our intestines. It's called the peritoneum. We actually can inflate that space to give us room to work. And so, you hear about somebody getting a laparoscopic gallbladder removal or something like that. They're making very small incisions. They're inflating the belly with gas, and then they're using surgical tools to remove the gallbladder. With robotic surgery, we're now inflating the belly. We still insert those skinny tubes, and then we attach the surgical robot to that, and then we can insert instruments through that. And now we can do much more complicated surgeries with laparoscopy but now we're doing it robotically. We call it robotic-assisted laparoscopy. You can also use the robot in other organs, so it's not purely a laparoscopic tool. You could be thoracoscopic, and chest surgeons can use it to remove lung tumors. You can use it in the oral cavity to remove, deep throat tumors. So there's a lot of different ways to try to use the robot. But the way that urologists are primarily using this is for advanced laparoscopy.
So how long has this technology, the robotic technology, been around for in clinical practice for removal of the prostate for prostate cancer?
Right. So the Da Vinci robot was first approved by the FDA for general laparoscopic surgery in the year 2000. And this came around from the merging of really two companies, Computer Motion, at least a lot of the materials or some of the intellectual property from Computer Motion and the Stanford Research Institute. And then they changed their name into Intuitive Surgical. And it really took off. Urology was an early adopter. I think we were looking for an easier way to remove the prostate gland, and pure laparoscopic radical prostatectomy was an extraordinarily difficult operation to do. I remember seeing a few of them and just believing, how on earth can anybody possibly do this operation? But then when you added the robot in now, it kind of became something that was within the realm of something that human beings can do. And urology really started to move with this. And so radical prostatectomy, we moved on to partial nephrectomy and a lot of other reconstructive surgery. And now, it's really done quite all, now we take bladders out, we do full intracorporeal bladder reconstructions. And now other specialties are into this. Gynecology was an early adopter as well. General surgery was a later adopter, but now they're really taking off primarily with hernia type repairs, but also with other types of reconstructive surgery. And really now, I think the biggest growth is in thoracic surgery. It's really, when you watch those surgeries with the robot, it's really quite neat to see them.
So from a training standpoint, what are some of the challenges in teaching surgical trainees robotic prostate removal surgery?
Yeah, Garrett, as you know, this is an extraordinarily hard operation to do in the first place. There's sort of narrow margins for error in terms of getting good outcomes. And the learning curve is what I would like to say is pretty shallow, meaning that it takes a very long time to get good at it. And when you're teaching surgical trainees, they're, sort of innocent in the sense that, they don't have a big background in, they know the anatomy, but they may not understand the tissue handling and these types of things. And so, it could be really trying on a teacher's patience, but at the same time, I think it's really critical that we have a large group of well-trained urologists out there that are performing this operation at a high level. So a lot of it is just the fact that it's a very difficult operation to begin with. And there's so many little nuances and tiny steps to it that can either help you out a lot or can make the operation really difficult. It's one of those things where, if you get into just a little bit of bleeding, if you kind of move through that, you're actually going to be, saving blood loss because you can move a little bit more quickly. But I do a lot of things from, working with my anesthesia teams just to try to make sure that we're doing the operation in the best possible way, making sure that my surgical teams around me are completely understand what I'm doing. And then, trying to, put the residents into a safe environment where they're maybe be doing parts of the operations where they're absolutely going to have no impact on the outcome of that patient, but they're still going to be able to learn tangible parts of the operation and eventually be able to do those in practice.
So from your experience, what advances have you seen which have really helped accelerate the learning curve for those learning how to perform robotic prostate removal?
Yeah, so believe it or not, I operated on the very first Intuitive robot, the first Da Vinci, which was the standard device. And when I think about how that robot was compared to the robot that we have now, we now have much better visualization. The attachment of the robotic arms to the patient, the placement of the ports is, I think, considerably easier. We can use different things. I don't use something like Firefly, for instance, that often, but I'll actually, flip it on and off. If I'm doing a bladder diverticulectomy, I think it can kind of help if you have a flexible cystoscope in the bladder, somebody's holding onto that and you kind of get the scope into the diverticulum, then you can kind of turn on and off your Firefly so you can actually more easily see where that diverticulum is because it's sometimes a little mysterious. Just the fact, for the thing for me really that I think is most impressive is just the reliability and the durability of the robot. I mean, we'll occasionally have some minor technical issues with it, but I mean, in over 1,000 procedures, I can count on one hand the number of times that I've had any sort of, modest failures of the robotic device, in almost all those circumstances, we were able to still recover it, either, move one arm somewhere else if an arm had a catastrophic failure, but we were able to still complete the operation. So it's really, really unusual that the robot breaks down. So I give Intuitive a lot of credit for making an incredibly reliable surgical device.
And, I think one thing that as a resident helped me, I think we were able to have kind of a simulation labs too, and, where we could actually go through and perform simple tasks, just, without the patient in the room. And I thought that really helped, to initially get familiar with the robot too, and just to kind of with the controls and so forth.
Yeah, and I'll back up and talk more about the learning curve here. So the dual console is a big winner. Now we have a way that I can easily pass the instruments back and forth between the trainee and myself. So if I don't like something that's going on, or they're just not doing it exactly the perfect way, I can, within a second kind of pick up control and just take over. And I'll take over for 10 or 15 seconds. And that actually really kind of simulates what we do in open surgery anyway when we're training residents. So, the fact that we step in, make a small change or modification, and then kind of get a trainee refocused. The simulators are nice as well. When I was training, we used to have to use training instruments and actually hook the robot up in a real world environment. So we'd be using real suture. We'd have to come in on a Saturday, and usually, because even those instruments were reposable, and actually every time you used them, you only had so many uses with those. We would try to batch, a bunch of residents coming in on a Saturday morning to do this. But now with the simulator, we can have residents come in, almost in between cases. It's just a matter of kind of, unplugging one of the connectors and then plugging in a different one, and they can get on there. They could actually do some pretty tangible simulation. And it's just a backpack looking device. This is all virtual. There's no real, we don't have to use suture. We don't have to batch people. We're not using real instruments, but they actually get the motions down with that. Surgical videos, I save almost all of my videos. A lot of residents have actually taken those and said, I want to learn how you do this. Take the video, go home, learn it. And we now have a pretty well manicured version of several of the operations, not just ones that I do, not just radical prostatectomy, but other operations as well that some of my partners do as well. And they're actually either sped up or they've cut out kind of the accessory parts of the operation. They can really just focus in on one short part and actually, get the details of that in, just a couple of minutes.
Yeah, I found that very helpful too, not only in residency, but out in practice too. Early on, just, just to kind of, it's almost like a muscle memory, just kind of the day before going through in your brain, kind of the steps of the operation, kind of visualizing it. I thought that was very helpful come the day of surgery for sure.
Oh yeah. I tell residents that want to do this operation, you need to be a student of the sport. And you need to be continually learning. So sometimes if I go to a different city, I'll try to take that opportunity to actually, contact a surgeon ahead of time. And if they're doing a radical prostatectomy, I want to go watch and see things that they do. So if you try to find the people out there that are operating at a pretty high level, try to take away some things, ask them questions. I think those are invaluable. Watching, videos of people that operate at a high level. And then, the AUA has done, I think, a very nice job of continuing to publish learning materials on video that you don't even have to go to the AUA. You can watch these, some other time as an archived visual material. So yeah, those are really valuable.
So I credit a lot of my success as a robotic surgeon to some of the early work that I've had working with you during my urology residency training. Now, I'm sure this has even further evolved since my time there as a trainee. And I think you kind of alluded to a few of these things, but any other, thoughts in terms of your current approach in teaching urology residents robotic prostatectomy?
Yes, you were part of our robotic training pathway, I'm sure. So what we start with is we have residents, they go through a process where they actually get observed as they're bedsiding, and we go through a checklist to make sure that they're doing a good job there. They have to do the online curriculum for Da Vinci, which seems to change a little bit, from year to year, but it does give them a basic understanding of the device and then kind of helps them learn the names of things and have some videos that patients watch. So we have this manicured video library that we've created. And then we have a program that they'll go through on the simulator so that they go through, so they know, okay, well, we went through and said, well, order that Intuitive has in the simulator may not make a lot of sense. So we actually went through and kind of reordered it based on the difficulty of it. And trust me, some of the exercises in that are incredibly difficult. I have a tough time getting passing scores on them. And so if you can kind of work through those, I still think it's really valuable. And then as far as robotic prostatectomy goes, we start to work the residents through 9 different parts of the operation. And I have to give one of my friends in urology credit here. So Jordan Luskin, recently a urologist in Montrose, Colorado, and is moving soon to Florida. But he told me when he was at Georgetown that the way he learned it from his proctor there was they had 9 different steps of the operation. And I apologize, I don't remember the name of the guy that I got it from. I'll try to, get that to you and put it so you can put it in the show notes.
Sure.
But so I do want to give the surgeon at Georgetown credit here. But we've basically broke this down into several different parts. And then the order is not necessarily sequential in the operation. So there are some things that are very straightforward. So mobilizing the bladder off of the anterior abdominal wall and doing some of the lateral dissections of the prostate, not the nerve sparing, but just incising the endopelvic fascia. And then we'll work through, maybe I do the posterior approach, which I think is the best, and I could go on and on about it. But, if you do the posterior approach, actually dissecting out the vas deferens and seminal vesicles, that's one of the more straightforward parts of the operations, but there is some peril there because the nerves are close by. So we need to try to teach residents how to be very careful with their electrosurgical instruments. Moving into the lymph node dissection, moving into the bladder neck dissection, the nerve sparing, the apical dissection. And to be honest, some of the residents don't work their way all the way through this, but I think if you can kind of work through posterior dissection, mobilizing the bladder, lymph node dissection, bladder neck dissection, and then the urethrovesical anastomosis, if you can get those parts down here, and then just understand that you need to be petrified of the rectum and try to do whatever you can to avoid that. And you'll get comfortable with where that is over time. If you keep those in mind, you can do those skills. And I think, just about anybody can gradually learn this. And, and then eventually get to the point where, as a continual learning that they still try to watch videos, still try to follow their outcomes and track them very closely, try to learn from their mistakes and become a great surgeon to do a robotic prostatectomy.
Well, it's certainly a great approach, and I definitely credit, again, a lot of my success and skill to some of those early, foundations that you laid out for us. So now, we're really nearing the end here of our time on the podcast. Dr. Maroney will actually be sticking around just for a few minutes to film some bonus video content, which are going to be including on the upcoming Prostate Health Academy. So for those men with newly diagnosed cancer, we're just going to be chatting a bit about his thoughts on how to go about actually looking for a good robotic prostate surgeon. What are some questions maybe to ask your surgeon? So you're not going to want to miss out on that when we go live. So just, to sign up for the Academy waitlist, just go to our website at www.prostatehealthacademy.com and click to sign up for the waitlist. So Dr. Maroney, any final thoughts for our listeners today?
Yeah. So, if you're a resident listening to this, just realize, you don't come out of the womb knowing how to do a robotic prostatectomy. It takes a lot of training and a lot of effort, working on the simulators and so forth, having mentors and partners that are able to kind of help you and teachers that are able to help you learn this. But I really, I have to give credit here where, when I was just learning how to do this, I was learning from people that were learning. Now I think we're in an era where we can actually have people that really know how to do this operation, teaching our trainees how to do it. And so I think, through the 2000s, it was pretty tough. But I think moving, forward, that we're going to have really well-trained robotic surgeons coming out of urology residency programs.
Well, that's great. Well, definitely a pleasure having the opportunity to chat with you today. Really greatly appreciate you sharing your time and knowledge with us today on the podcast. So thanks again.
Oh, thank you, Garrett. This is great.
Thank you again for listening to the Prostate Health Podcast. Follow me on Twitter and Instagram at gpohlmanmd. Don't forget to join us next week for another episode.